Welcome to This Clinical Life. My name is Stephen Beeson. This Clinical Life is proudly presented by Practicing Excellence. In this podcast, we explore the transformational impact of helping and supporting and growing the talents of our workforce, an often untapped resource for organizational transformation. And incredibly honored today to have with us an amazing guest that I've had a chance to get to know, Kathleen Reeves. Kathleen Reeves is president and CEO of the Arnold P. Gold Foundation. She previously served as professor and chair of the Department of Urban Health and Population Health, director of the Center of Urban Bioethics, and professor of clinical pediatrics at the Lewis Katz School of Medicine at Temple University, a distinguished champion for humanism in healthcare. I love that about her. Dr. Reeves is committed to working with leaders across disciplines to elevate the patient-clinician relationship and achieve the Gold Foundation's mission to advance kind, safe, and trustworthy care. Kathleen, welcome.
Thank you. It's a great honor to be here today.
Oh, you bet. So tell us your story and how you got here as a sort of a national advocate for humanism in healthcare. How did you get to where you are right now?
Well, like most things for most of us, I never imagined my career would lead me to this space, but I am extraordinarily fortunate to have this position. So I think when I look back at my career, my whole life's work has led me to this point. I have spent most of my career in urban distressed populations. I'm a pediatric hospitalist, so I take care of children who are hospitalized. And I've been an educator throughout that whole time. And what I've really noticed throughout my career, which is why I started the Center for Urban Bioethics, it is all about connection. The science doesn't really matter if we're not connecting to people. And in fact, we can do more harm than good if we aren't connecting to people. And I saw this again and again with the families I had the privilege of serving in North Philadelphia. But I think the place that nationally we all saw that was COVID. Even in my experience in Philadelphia, I didn't see vaccine hesitancy. I just saw a lack of trust. We were giving the vaccine in our hospital literally on one side of Broad Street, and nobody was coming. And when we asked the community, they said, because we don't really trust you. And when we moved the whole program of giving the vaccines across the street to a very trusted church, we had a waiting list that was pages and pages long.
Wow.
So those kind of experiences led me to the Gold Foundation. And the more I learned about the Gold Foundation, the more I saw this as an opportunity to bring this message to a national stage. And the Gold Foundation has been around for 40 years and started with a pediatric neurologist, a little bit of the same story. He was rounding at Columbia, the children's hospital there, taking care of a patient whose name was Glenn, who had a brain tumor, a 16-year-old boy. And he was talking to his residents and students about the patient. And they knew everything about Glenn's disease, every medicine, every side effect. But they really didn't know anything about Glenn. And Arnold started the conversation there. How's he doing? How are his siblings? How are his parents? And they couldn't answer any of his questions. And this is before the electronic medical record. There weren't even MRIs yet. And Arnold asked, okay, I'm going to show you how to connect with patients. What's his name? And they didn't know his name. So he started the foundation to really champion human connection, no matter how much science advances. And he started the whole thing with the white coat ceremony, requiring students to take an oath before they ever have an opportunity and a privilege to work with patients. So it really isn't about the white coat, it's about that oath. And we hopefully are going to carry on that mission into very practical solutions moving forward.
It's extraordinary to hear you talk about the stories of trust and human connection and clinician-patient bond. It's vitally important for the ability for us to render a clinical outcome and even enrich our lives. I want you to tell me a little bit more about the Arnold P. Gold Foundation itself and sort of the activities that you're doing to help advance, connection throughout healthcare and humanism throughout healthcare. I would love to hear sort of the work that you're doing right now, what sort of progress you're seeing.
Sure. So I've been in the position for 18 months now. And prior to me, the work that has been done is extraordinary. The foundation has really built a platform that makes humanism central in education, that recognizes exemplars like our Gold Humanism Honor Society, recognize the students who are going to be leaders in humanism moving forward. We give a number of awards to really recognize and bring merit to how important human connection is. Where I want to go now is to build on this amazing work and bring very practical solutions to how we can connect, and then to prove that they work. I believe that there is great science in humanism. I think I said this to you before. I finished residency now 30 years ago. And if I did many of the things I learned as a resident today, it would be malpractice. But humanism is true. The science behind how trust, how kindness, how making sure people feel safe and feel cared about helps them be healthier and us be well, that evidence is clear. And there's even great evidence that this will save us money. We just aren't intentionally embracing it. We think it's the soft side of medicine. You either have it or you don't. It just happens. It has to be intentional. It can be taught, and it has to be measured and valued.
I'm nodding my head. I mean, this is such a powerful testimony, and uh, I think it's a critical coupling to the diagnosis and management of a disease to be able to render advance of wellness for the patients that we take care of. If you were to sort of articulate, the evidence as to why patient connectivity is so important, because I think philosophically we all say, yes, humanism and patient connectivity, really important part of delivering care. There may be some cynics out there to say, my job is to diagnose and treat and apply evidence to a clinical condition to create and render a cure or improvement. What is the evidence from your standpoint that humanism coupled to diagnosis and management of disease is important?
So health and healthcare don't happen without connection. There was a JAMA article even before COVID in 2018 that shared 60 to 80% of patients today aren't sharing something important about their health with the professional taking care of them because they don't trust them. They're afraid they're gonna feel judged or shamed. I don't care how smart we are. If people don't tell us the whole story, if they don't feel safe enough to share their vulnerable moments with us, if we aren't trustworthy enough for that, we're never going to have the right diagnosis. And if people don't trust us, they're never going to be able to enact the suggestions we have for their care. And we're not going to be well because the physicians and nurses and nurse practitioners and physicians assistants I've met are very, very good people who want to do good things. And to be able to do that, we have to enter into a relationship. Can I share one quick story, an example of that?
Oh, you bet.
So when I was a younger attending, I was covering the emergency room, and it was a adult hospital that saw children. So I was taking call from home, but would sometimes have to come in if there was a situation that required that. So there was a grandfather, this is in Chester, Pennsylvania, a very small, a mid-sized city that really struggles from poverty and from a lot of distress, but a very, very strong community with a lot of social capital. And a wonderful grandfather who identified as a Black man came in. He was caring for his grandson, who was a month old, and his grandson had a fever. And if a 1-month-old has a fever, the care is pretty clear. You do a blood culture, you get a urine sample, you do a spinal tap to get cerebral spinal fluid, and then you start antibiotics until you're sure none of those fluids are infected. And the grandfather listened intently as a resident. This excellent, excellent resident is explaining all of this. And he says, I want to do what's best for my grandson. You can do the blood culture, you can take the urine, but I'm not gonna allow you to do the spinal tap. And the resident says, but you have to. And the grandfather says, no. And you can envision this, right? It just escalates to the point that the resident says, I think what you're doing is child abuse. I'm going to have to report you. And before that can happen, the resident calls me as the attending. So I come in, and obviously this grandfather really cares. So I make the assumption he really cares. So what's the next logical conclusion? To connect with him. Just ask him why he doesn't want the spinal tap. It seems so simple. But the connection is assuming that he is a person who wants what's best for his grandson. And he says, because I don't know if you're going to be taking fluid out or putting something in. I have seen healthcare that's I don't trust. So we just said, what if you're in the room with us? And he said, okay. So that connection in that situation changed from not being able to provide the care and creating great distress in that family to not having that distress and being able to provide the care. So that example is proven again and again in the literature that trust brings health, that when people feel cared about, they're healthier, they return for care, they're able to enact care plans, they're able to tell us their whole story.
Well, I think that that story is being, as you referenced, replicated as we speak thousands of times per hour in American healthcare.
Yes.
And I remember reading an article a number of years ago where patients who participate or patients in the top quartile of trust for their clinician versus in the bottom quartile of trust in their clinician, the likelihood of participating in a treatment recommendation was about 68% for those in the top quartile of trust and about 28% in the bottom quartile of trust. So all of us as clinicians are about what are the interventions we can do to advance, again, the wellness of our patients. And without the coupling, if you will, to human connection of I care about you, I hear you, I see you, and I know you, then all of the diagnosis and treatment modalities that we have are deleveraged and almost entirely lost. You know, I'm not going to do the LP. I'm not going to get the diagnostic test. I'm not going to fill the prescription. I'm not going to get participate in the treatment plan. It's the ultimate capacitator. One of my other questions is how we approach the interaction as we walk into the exam room doesn't always facilitate connection. Talk us through the sort of clinical encounter and actions that we take as a care team member that facilitates connection versus sort of the historical history and physical examination that we've been trained around.
Yes. So I think it's really interesting that we have structured our entire way of interacting with the person sitting in front of us around a problem. And if we're talking about connecting with anyone in our life in any other space, we would never start that connection with a problem. And the way we teach how to interact with a patient, the very first thing after we introduce ourselves, what we're teaching students is start with a problem. So what's your chief complaint? Or some people will say chief concern. In my experience as a hospitalist, when I meet a family, if I start with that, the whole room deflates. I'm meeting a family after they've spent hours and hours in an emergency room, very stressed and worried about their child. And then they come up to the floor into their room and meet me. And I, again, start with a problem. If I just say, and it takes me about 7 seconds, oh my gosh, you must be really tired. Your daughter's so lucky you're here. Tell me something about her. Then the whole dynamic changes because they know I see them as people. They know I recognize that they've just been through a really hard time, and they see me as a person and not as this figure of doctor or healthcare professional. And it isn't just an exchange of knowledge or medicine or what treatment you're going to get. It's a connection where we see each other as people. And I feel a whole lot better after that interaction as well, because the patients are smiling when I say that instead of just slumping down, and they're looking down and being exhausted by yet another opportunity to talk about the problem.
When I coach and observe clinicians, I see that exact pattern. Everything is about, everything that sort of the capstone of the entire clinical encounter is about an evaluation of a set of symptoms to identify underlying root cause to issue a treatment plan. And again, managing hemoglobin A1Cs and LDLs and hypertension and peak flows is fun and everything. But I would contend your experience, my experience, and a whole bunch of literature and everything that I've observed is that the best of medicine is finding the story of the people that we treat and treating them in a way that prompts a response of human connection. And the high school teacher with 4 kids whose youngest is applying to Stanford, and you get to know that teacher as a patient is a whole lot better than a hypertension follow-up. And
Yes.
yeah.
One of the tools we have at the Gold Foundation is something called Tell Me More, which is this very seemingly simple program, but it changes the world for patients and clinicians. It is simply either a big poster that goes on the wall, or it can be on one of the digital whiteboards that are in the patient's room. And on that are 3 or 4 things about that patient that have nothing to do with their disease.
Hmm.
I'm a New York Jets fan. I have a wonderful garden, and I have 9 grandchildren. There's going to be something on that list that whoever walks in the room is going to connect. So a Giants fan walks in, and the room erupts in laughter eventually because they're arguing about the Giants and the Jets. Then the rest of the conversation changes. And then maybe the gardening comes up when they're talking about they had knee surgery, and they're talking about recovery or what are the side effects going to be. Bringing in the gardening, bringing in the grandchildren. You're going to want to get up and down off the floor. You're going to want to be able to do these things. And even when you bring up things like hemoglobin A1C, bringing in the positive parts of the world, we know from motivational interviewing, if we only tell patients about what they're doing wrong, they're not going to change their behavior. They're not going to be empowered to do so. But if we tell them you are doing lots of things really well, they're empowered. So yes, the connection has to be intentional, and it has to be throughout the interaction.
It's interesting. I've always sort of categorized clinician willingness to participate in something around will and skill, right? They have to have the skill to do it. What are the behaviors that I can do in the exam room that allows me to connect to a patient? And I have to have a willingness that this is worthwhile doing. What are you seeing in terms of clinician will when you speak and when you advocate and when you have tools like Tell Me More? What are you seeing among trainees as well as attending and more senior clinicians about and care team members about the willingness to participate in behaviors that facilitate human connection? Is that something that's being widely embraced where you are? What are you seeing? What are you observing?
First, what I'm seeing is a great excitement to want to do this. I see smiles and head nodding, and this is what people want to do. But I think they feel trapped. They feel trapped in a box of culture that we've created that doesn't allow this. It is definitely not the default, nor is it really rewarded. So you've got to swim against the current to do this in the way we're set up right now. And I believe patients and healthcare professionals would be so much happier and healthier if we could create this space where this was the norm. Like for example, my world again is in the hospital. So if we're really going to take care of ourselves and take care of patients, before we ever walk into a room, we should take a minute. We should probably take 3 or 4 deep breaths. We should make sure whatever just happened 5 minutes before, we're not bringing into the room, that we're ready to be present for that patient, that we will sit down and look at that patient on eye level. Those are not things that we see happening. And we see these as things that slow us down. We teach that. I still remember being taught, the good doctor can stand at the doorway and tell what the patient has and if they're sick or not right away. That's the antithesis of connection. We don't want to do that. If so, what I'm seeing is healthcare professionals who really want to do this, but don't know how to change the culture enough so that it's not so hard for them to do this.
It's so interesting as I hear you talk about what it does to the clinician. I think there's, as you referenced, there's very compelling literature now. I think at last count, about 57 published, well-designed studies, many observational, that our connection to patients enriches the lives of those that are providing care in a significant way, meaning
Yes.
we are the greatest beneficiaries. Of course, patients are going to be the recipients of kind, compassionate, connected care where they know me, hear me, see me, and are advocating for me. But it allows clinicians and care team members to be the clinician that they envisioned. I think when we live in accordance with this is who I thought I was going to be in this clinical life, and to actually be that person by connecting to patients with techniques and approaches that go beyond just the diagnosis and treatment of disease, it's so powerful for the clinician and fully accessible. We get to decide who we are when we go in the exam room. Um, One of the other things and questions I have for you is that it's about, changing a culture. And part of the changing of culture is us as individual care team members to say, I'm going to make a commitment to connect with patients and we have full dominion over that micro interaction and who we are. But how might we begin to broaden that commitment so it's happening at an organization or a team level to say, we are going to be more connected to the patient's kindness and compassion and humanism for every patient every time? How would you, for anybody listening, how might we advocate for that to occur organizationally or across a team so it goes beyond just the one-on-one decision?
Yeah, that's where the rubber hits the road, right? And how can we make organizational culture change. So first I want to say, when we want to make change, we are good at it, right? Look at what we did with central line infections. When it became important that
Hmm.
we had to change that, we changed that. We changed behavior. Um, and 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 the reason it was so important, I guess, is where we have to unfortunately concentrate a bit. It was so important because we were going to lose a lot of money as institutions if we didn't deal with our central line infection rates. Running a healthcare system is a really hard job. The margins anywhere, hardly anywhere, are wonderfully large. So we are economically always struggling. And what we haven't done that so many other businesses have done is realize how cost effective it is to be kind, trustworthy, and safe. I've sat in so many meetings with hospital C-suite folks that it costs us so much money as institutions when patients don't show up for appointments. And we're putting that so often on the patient. But if you look at study after study um, in the Annals of Internal Medicine, in Journal of Pediatrics, people aren't showing up because they don't feel like we really care about them or they don't feel safe. So helping people feel safe enough and trustworthy and that we are trustworthy enough for them to come back for appointments is going to make us money and improve our margin. So I believe that the organizational change here will happen when we can show people in the C-suite that it is not only the right thing to do, it's a good business decision. The way we're trying to fix the margin problem right now as an organization is backwards because we're taking connection out. We're double booking. We're giving physicians less time. And I do think in the AI conversation, I run a humanism organization. I am also a big fan of what AI can do for us, as long as
Mhm.
we do it intentionally and we keep human people at the center. But I think the way to bring organizational change is to show people how it's going to bring health and it's going to improve the margin for health systems.
It's so interesting. I completely concur that the priority of executive leadership right now is around raising margin and diminishing, or raising revenue, diminishing cost, and widening margin. And I get that. You have to have a margin to be able to support the operations of a healthcare system. But if you look at the case, as you articulate, for human connectivity as an organizational trait commitment, just like zero harm, we're going to stop harming our patients
Yeah.
unnecessarily, right? Just a big, bold, this is who we are, kindness and compassion for every patient every time. What it does to out-of-patient migration. And if you look at the AMGA data, there's a top line revenue loss per employed physician of about $750,000 per physician per year. You talk about 100 physicians, do the math. It's ridiculous. And
Yes.
the cost of patient churn, it's 10 times more expensive to go get a new patient than it is simply to keep the patient you currently have. The lifetime value of a loyal patient, the patient who
Yeah.
becomes your ambassador and your evangelist out in the marketplace, where people still make choices by virtue of what other people say about you, and what it does to enriching the experience of the care team member to say, I am in a place and in a culture that represents the kind of care team member I want to be. And we're serving a mission that I really can believe in and makes me feel good about who we are and who I am. In addition to all of the clinical implications, in addition to all the malpractice implications, it's like, what the hell? Why,
Well, no one, yeah.
why can't we just make this instead of trying to jack revenue? Why don't we just keep loyal patients by creating
Oh,
humanism everywhere?
and it's amazing how, unlike any other business, yes, would we have to invest in this change? Absolutely. But we
Yeah.
can't afford not to. And we were part of the development of a very simple validated trust tool. And in that trust tool, what we found is when patients really felt their physician cared about them and they could trust them, their net promoter score was 24 times higher than when they didn't. I mean, a net promoter
Right.
score is like gold to
Yeah.
to hospitals. So those are the kind of things we want to measure and show why investing in this isn't just right. It is the best business decision.
It's so interesting. And I want to get your take on the application of a people development, skill development strategy to manifest evidence-derived connection behaviors. So we're actually doing it. What are you seeing about the impact of a skill development approach among care team members to better connect with patients? What do you see there?
So again, this is something we're really good at, right? We're really good at creating specific skills on how to do something when we learn that something needs to change. Even look at we did in the ORs whenever, now we make sure you're operating on the right leg. We have these specific timeout
Mhm.
structured things that are national. I think this is very, very doable and measurable. The National Board of Medical Examiners now has a whole new area of evaluating behavior and behavior change. So we are well positioned to do this. And I think it would look something like this. You walk in the room and you create connection. That's your CC, not chief complaint. As you're creating connection, you realize cultural humility is how you have to connect with someone who's very different from you many times.
Mhm.
Ask about them and know your community. I'd like to talk about personalized medicine as so much more than what your genetic code is. It's about your address. We're going to come a long way when someone tells us their address and that means something to us. We know what that means in the community we serve. Consciously assume they want to be healthy, they want their family to be healthy. That's never gone wrong for me. I'm not going to get taken advantage of by a patient. And always follow up. Always follow up with your patient. If you're a hospitalist, you go back later in the day. If you're an outpatient doc, that follow up is what's going to bring them back. We know that from studies we've done around trust. People want you to check in again, and then you've won them for life.
It's so great to hear you tell the stories of specific tactics that can be applied in the context of a clinical encounter. And I've seen that happen myself and with clinicians that have been coaching, that a couple of simple actions, one of my favorite ones that we coach at Practicing Excellence quite a bit is asking patients, what about all that you're going through right now worries you the most? And we get to discover this incredible, these fears, worries, and anxieties that we were focused on the chief complaint of, but it opens up this entire new illuminating reality of where the patient's coming from and just the signal that sends to them that I see you, I care about you, and what matters to you matters to me. And that will be the focus of our partnership in the clinical journey. And the other technique that I encourage physicians to think about is envision what it's like to be this patient in this moment, what that
Yes.
might be like, and allow that to inform you how you show up. And it's so beautiful to be able to be encouraged by what you're saying. There's simple things that we can do in the exam room. There's a commitment we can make at an organizational level with lots of different ROI implications. and what it does, most importantly, I think, for the care team member and what it's like to be the kind of clinicians that we've always wanted to be. Um, I, I'm I'm so encouraged by champions like you that are out in the world advocating for humanism in healthcare. I guess my final question is for those that are in systems and in cultures where they're going, this is not what's happening where I am, and for them for listeners to say, what is the thing that I can do that might help this humanism, this connection cause that I think we're all embracing and supporting and connected to? What would you say would be a good next step or action they could take to help advance humanism and connection where they are?
So especially if they're a place that they feel like they're not seeing change, um, but especially if they are a change maker, which many of us are, as leaders or just faculty at institutions. We are so much exponentially stronger when we are working together. And I believe one thing about medicine, I would always one of the examples I would always use when I teach is in the nursery. I know this is going to be a funny example, but every baby blanket across the country is pretty much the same. They're white with light blue and pink lines across the blanket. There are so much similarities across our institutions in how we actually interact, how it's set up. We all take part in a history and a physical in a very similar way. We almost all use Epic or some similar electronic medical record in a similar way. So what I would encourage people to do is reach out to me and let me connect you with a similar institution that is seeing change. See it from another space, get some advocates, get some allies, because the people that are seeing the change, once they see it, you can't unsee it, and they're going full force forward. So join together in the movement to bring change. I mean, that's what residents are doing, right? Residents are changing residency, whether it's through unions or going together, they're coming together. If this is important to us, let's come together and make that change and make the case to your C-suite. I'll help you. I'll get you in touch with an institution that will help you bring the business case to why your leaders, not only should they do this, they can't afford not to. 24 times increased net promoter score. Nobody's gonna ignore that.
Yeah. And and I think in the end, we have full dominion over who we're going to be in this life for the patients. And there's real power in that. And there's such power in coming together and advocating for it. There's power in deciding to step into the C-suite office and say, I have an idea. And there's other organizations that have done this. Again, I was part of Sharp Healthcare, and we made a decade long journey committing to kindness and compassion and connection to patients and each other. And
Yes,
it was a wild transformation from quality, culture, economically, patient experience, team member engagement, turnover, all of it.
yes,
And the centerpiece of it was we as an institution make a bold commitment to kindness and compassion for every patient every time. It was hard as hell. It took a long time,
and
but
for every healthcare professional every time.
yeah, it
Yes,
is. And the other last comment is the power of investing in your people to develop skills to connect. Because I
yes,
can tell you as a clinician, I didn't learn that. I didn't learn evidence-based skills of
yeah,
human connectivity. I was very good at differential and doing the history and physical and
yes.
all of those things. But the skills of human connection to teammates and patients, I think is the capacitator for that humanism in healthcare. It's a really important strategy.
Totally agree. And I want to thank you too for what you do, because you touch so many spaces and help so many clinicians directly bring humanism to healthcare. So the future is bright. We just have to work together.
there's a lot of clouds out there still. So, Kathy, I so respect and honor the work that you're doing as an advocate for humanism in healthcare. We have so much on the line, and it's just the right thing to do. And declaring it to the C-suite, making a personal commitment, applying human development, national advocacy, connecting you, connecting with me, whatever. We can all become champions and advocates for greater humanism and connection in healthcare. And so appreciate you being a part of this clinical life.
Well, thank you. It was a great honor to speak with you.
Okay, take care. We are out.